So in this talk, I'm going to speak to you a little bit about the global situation in terms of access and availability of opioids for cancer pain, before focusing on 3 studies which we've undertaken exploring the implementation of international drug policy. So the World Health Organization takes the lead in terms of producing guidelines in order to encourage safe prescribing practices around the world, producing a range of different guidances for adults and for children. And I was at a conference recently in Japan where we had an hour-long session on clinical guidelines for opioids and opioid prescribing. And this was very interesting, and it was talking about different formulations and different modes of administration. And it's really important work to make sure that prescriptions of opioids are safe and effective for the patients. But at the end of the session, a colleague of mine from Malaysia came up to me and said, they could have at least acknowledged that we have none of these medicines in my country. And this is the reality for most people around the world who have very little or no realistic chance of ever receiving an opioid for pain from cancer or any other clinical indication. In fact, this is the reality for most people around the world. Many of you will have seen this slide before, but I make no apologies for showing it to you again, because to me, this sums it up. In terms of this, on the left, we see this gentleman in very clear distress and having not been given any kind of treatment for what is evidently very, very serious pain. So we can see the human impact of lack of access to opioids for cancer pain on the left. And on the right, we see the transformative impact which just a single dose of oral morphine can have for a person. Then opioids, like oral morphine, are some of the cheapest medications which are available worldwide. But despite of this, it's other factors, structural problems and availability of services, which have meant that this man has spent so much time in the circumstances that we see on the left. And we're going to explore some of the reasons why this situation is something which continues to happen around the world in the next 15 minutes or so. So despite the seriousness of the issue, until 2014, palliative care and access to pain treatment received very little global attention and wasn't spoken about by global health agencies. The global health priorities focused upon the reduction of preventable deaths, tackling infectious diseases, and the key goals were around increasing life expectancy and promoting economic growth, 2 things which tend to go hand in hand. There have been great successes in terms of reducing avoidable deaths and increasing life expectancies around the world. But paradoxically, this is, in terms of the palliative care community, this is something which might actually increase the need for palliative care around the world. As people live longer, they do so with increasing likelihood of developing diseases of chronic complex, and people may live longer with palliative care needs. Things changed somewhat in 2014 with the designation of the World Health Assembly resolution on palliative care. And this was a really important moment where the World Health Assembly passed a resolution acknowledging that access to pain treatment and palliative care was a global responsibility and the responsibility of every healthcare system worldwide to integrate palliative care at all levels of their healthcare systems. So this was an important moment for palliative care, and it was agreed by all WHO member states. However, what's also important about the resolution is that it's a non-enforceable resolution. The countries sign up to it, but no finances were made available to help to support countries to implement the terms of the resolution, and therefore implementation continued to rely on the actions of national governments with little practical support from the global level. Things changed again in 2015. There was no mention of palliative care in the previous global health priorities, the Millennium Development Goals. In 2015, the Sustainable Development Goals included a clear target to include the attainment of the World Health Assembly resolution on palliative care within efforts to achieve universal healthcare coverage, the key global healthcare priority. However, even so, palliative care lags behind somewhat in terms of how we measure, we struggle to describe what availability of palliative care service means. We struggle to measure what we mean in terms of people accessing palliative care. And this leaves the danger that palliative care could be overlooked within efforts to achieve universal healthcare coverage. And it's important for the palliative care community to use language like universal healthcare coverage when we're talking about palliative care development worldwide. And this is a significant problem. The palliative care is a global healthcare issue, partly due to the severity of suffering which happens at the individual level in the absence of pain treatment and palliative care, and partly due to the numbers that we're talking about. The World Health Organization estimates that 56.8 million of people need palliative care worldwide. However, worldwide, only 14% of people who need palliative care currently receive it. Most of the need for palliative care, and particularly the unmet need for palliative care, is to be found in low and middle income countries, which makes it a key global health inequality. And of particular relevance to my talk today, in 2021, 81.1% of the world's population, mainly in low and middle income countries, consumed only 14.3% of the total amount of morphine consumed worldwide. So consumption of morphine between countries is a key global health inequality, with consumption primarily in North America, Western Europe, and Australia. And as I said, as life expectancies increase, people live longer with greater risk factors for developing longer-term illnesses like cancer. And we can see from the graph that since 1990, when the Millennium Development Goals were agreed, just over 40 million people were living with cancer worldwide. In 2017, we see that nearly 100 million people were living with cancer, and these figures are on an upward trajectory and set to increase further, which overall is going to increase the global need for opioid treatments and for palliative care more generally. Excuse me. Of particular relevance for low and middle income countries, currently around 80% of cancers are diagnosed in low and middle income countries when already advanced. So this points clearly to the need to earlier identification and better diagnostics, but in reality also means that that when most people are diagnosed, they will already be very likely to have needs for pain treatment and palliative care services. And some of the barriers to opioid availability worldwide are quite well described. In this survey of 214 countries published in The Lancet, these were the factors which were reported by participants to be the key impediments to access to opioids in their countries. And I want to pick out just two or three of these. I think of particular importance, fear of dependence is notable on this list. We know that in many circumstances in low and middle income countries, if people are lucky enough to ever be offered an opioid, they may be offered an opioid only within the last days or weeks of their life. Despite this, we find that people are still refusing opioids or very hesitant to take an opioid due to the fear of dependence. Even though they may only have a few days and weeks to live, the fear of addiction is still there. Fears of diversion. We've seen in North America and in a selection of countries what happens in the context of overprescribing within complex socioeconomic circumstances where there have been instances where legitimately prescribed opioids have been diverted for illicit use. And these kind of fears of dependence and fears of diversion are pervasive, and they feed into or are led by onerous regulations, which very much focus on the control and restriction of access to opioids in different countries. So how did we get here? Sorry, excuse me. The Single Convention on Narcotics has been international law since 1962. And has framed all national regulations since then. Unlike the World Health Assembly resolution on palliative care, the Single Convention is enforceable. It's international law, and countries face sanctions for failing to comply with its terms. And the Single Convention aims to promote access to opioids for medical and scientific purposes, whilst restricting illicit use and production of narcotic substances. And by way of enforcement, the International Narcotics Control Board requires that all countries worldwide report consumption and submit estimates of requirements to them annually. And estimates are the quantities of controlled substances which they estimate will be needed to meet the clinical needs of their populations in the following year. But the INCB has been criticised for increasing the fears and concerns around opioids are not doing enough to promote access for medical and scientific purposes. So we investigated this in this study by looking at the every annual report of the INCB since they started. And we extracted all of the keywords relating to opioids, opiates, narcotics, and we coded them to say to find out the circumstances in which these type of terms were being used. And what we found was that in every single INCB report, that discourse on abuse and dependency and the illegal drug trade predominated and was the dominant discourse within annual reports. Much less attention was paid to access to opioids for therapeutic use, despite the clear need for better availability and accessibility worldwide. And we also found significant discourse relating to the estimate system. So we wanted to look in more detail at the estimate system. Excuse me. And sorry, excuse me. And the INCB recommends three methods of estimating the need for opioids at population level. The consumption-based and service-based methods both look at the previous year's consumption and suggest that, that a similar amount will be needed in the following year. And the problem there is clear because if usage was inadequate in the previous year, then it will be likely to be inadequate in the following year. However, the morbidity-based method seems to be a little bit more dynamic and more responsive to changing disease burdens over time. And by way of implementing the morbidity-based method, the INCB recommends this calculation. They suggest that 80% of people who die from cancer will need 6.075 grams of morphine over the last 90 days of their lives. So we wanted, again, to look at this in more detail. And with colleagues, we retrieved the country's estimates of requirements. We retrieved cancer deaths by country since 1997. And we explored the proportions of clinical need for opioids which could be met if all morphine listed as a requirement by countries was directed towards the needs of cancer patients at opioid INCB recommended dosage and duration. And we found that only a tiny fraction of countries worldwide estimate requirements which even had the potential to meet anything like 100% of the need for cancer pain, even if we suggest that there is any veracity in the calculation around 6.075 grams. So there is a clear need to increase evidence-based methods of how we estimate the need for opioids at population level, firstly to support countries in making accurate estimates of requirements, but also so that we can hold countries accountable, so that we can look to see if countries are making any kind of progress to gap the need, to bridge the need between clinical need and what is happening currently. In a third study, we wanted to look at how the international and national regulations play out on the ground. And we conducted a systematic review of all studies which focused on this issue in the context of Asia. And we developed 4 themes, the first of which was legal, regulatory, and socio-political factors. And what we found was that the negative language around language seen in INCB reports is replicated in national regulations. We found no legal responsibility to provide pain relief, and so we didn't find a positive obligation for clinicians to be treating the pain needs of their patients. And we found onerous bureaucracy, where it becomes extremely difficult to go through all of the processes necessary to stock opioids, and to procure opioids, and of course to prescribe them as well. We found that many countries in Asia had little or no practical access to oral morphine. And in many circumstances, the strongest opioids which were available to prescribers were codeine and tramadol. Even when opioids were technically available, we found further limiting factors around accessibility of opioids. Despite the fact that oral morphine is one of the cheapest medicines available anywhere, we found that in some countries, only more expensive formulations like fentanyl were stocked in pharmacies. So cost became an issue where it didn't have to be because of the non-availability of oral morphine. More practical factors are present. We found people having to travel significant distances first to access the prescription in the first place, but also short-term prescriptions, meaning that the patient or the family may have to repeat these long journeys, often in desperate circumstances. All of these things feed we also found a lack of prescribers in most of the country, in many countries in Asia. And all of these factors are relevant. The negative climate created by national regulations, the consequent lack of educational opportunities in different circumstances, and we found a fear amongst prescribers about prosecution for making mistakes. So rather than a positive obligation, we found that they felt very restrictive and fearful about doing wrong in the context of prescribing. And taken together, we developed this conceptual model about opioid availability worldwide. The international level and the global policy and the implementation of the estimate system, negative language in international law, feeding down to negative language and an atmosphere of restriction within national healthcare policies. All of this leads to suboptimal consumption levels within at subnational level and at the individual patient level, a lack of services and human resources to dispense and prescribe medicines. And tragically, this is a self-perpetuating system, whereby inadequate consumption in 1 year is likely to be fed back to the International Narcotics Control Board and an upper limit on stocks and trade set for the following year. So that's quite a lot of information to give you in such a short time, I realise. But this is the global context in which we work. Global regulations frame national regulations, which are then implemented nationally. And the broad circumstances around the world is a general atmosphere of restriction. So I think it's really important in circumstances where we have reasonably well-functioning models of opioid availability that we do more to develop evidence-based methods in terms of understanding what population level for opioids needs looks like, particularly for cancer pain where the greatest need for opioids lies around the world, but also for other clinical indications so that we can support countries to refine their estimates of requirements. And also so that we can start to understand better the gaps between what's happening currently in different circumstances worldwide, and where countries need to get to. So, I apologise for something of a rush there, but thank you very much for listening. And if you do have any questions, I'd be very happy to answer them. I can chair from here, can't I? Mira, please.
I think there's a new emerging challenge. So I think one of the new emerging challenges as regulation around use in chronic pain has changed is that the market forces for this to be a viable business proposition for pharma to produce opioids, especially so I think in developing countries who have developed their own within-country production of cheap oral morphine, that's a different business model. But Australia, the UK, Canada, the US are relying on market forces and the companies wanting and being willing to produce opioids. So in the last 18 months, we've had issues with oxycodone, hydromorphone, and oral morphine liquid will be discontinued in Australia as of April 2024, which is just is a remarkable thing to even think that in 2024 we may not have oral liquid morphine in Australia. And so I think the global supply chain and the market forces for the legitimate evidence-based use of opioids, which has been driven by a non-evidence-based market, is going to be a very interesting quandary to tackle from an advocacy and policy perspective.
Yeah, thank you. The neoliberal model of globalization and the influence of transnational companies, it's a serious issue that the pharmaceutical companies might dictate that kind of thing. And yeah, I mean, we can see a need for reform and another approach, but I think, unfortunately, I can't solve that problem today. The Fliss.
I'm monitoring the questions online for you, Joseph.
Thank you.
So there's a question here from Kate Binney online. Do you think there's a relationship between colonialism, a history of exploitation of locally produced opioids by rich countries, and legal and social barriers to access at population level in low and middle income countries?
Yeah.
I'm just Is that the short answer?
I'll do my best. I mean, I think to some the clearest example of that I can think is the international law itself, and the formation of the International Narcotics Control Board. The high-income countries and historically those were the imperial countries. Formed these kind of organisations and did so from the start. And as we've seen, I hope in this presentation, it hasn't been in the interest of low and middle income countries, but this is still international law, and has been so since the 1960s. So my suggestions around improvements around working within the system, a more radical approach would be to tear the system down. So yeah.
Kate makes a very good point that in a way we shouldn't laugh because it's such an important question. I think we were probably laughing because the question was such a big one and we were all wondering how on earth you were going to answer it. So thank you for that.
Thank you. Lucia. Tim, Chair, I'm relying on you to interrupt as and when you like, but we'll go for a question from Lucia.
Thanks, Joe. That was a fantastic summary. Thank you very much. Is that actually working? I'll shout if not. I just was interested that you mentioned in the final paper there was a situation where you said some countries actually had more expensive formulations of morphine and not the cheaper ones, which obviously seems quite odd, but there must be something driving that. Did you have any sense when you were doing that piece of work why they ended up in that weird situation?
I think the Mira touched on it in terms of the influence of the pharmaceutical companies. Big Pharma is a huge advocacy. They have huge power for advocacy, and they want to sell their product, and so they encourage governments and they sell it. They're in the room with them, and they say these are the medicines that you need. And in some circumstances, as we saw, those are the ones that are made available. And again, it comes down to the influence of pharmaceutical companies. And the other side of the coin, when the opioid crisis in North America again was led by aggressive marketing from pharmaceutical companies. So it's a huge presence in the room in this conversation. The Fliss.
There's another online question from Kektian Tay, who says, thank you for the excellent presentation. I'm from Malaysia. I can identify with some of the barriers to opioid utilisation and access to opioids highlighted in the presentation. One of the strategies is to impose sanctions on countries not complying with recommendations. Do you know if that has been successful?
To some extent, I think the sanctions are much clearer for countries which don't comply with aspects of the enforcement directed towards the illegal drug trade and drug dependence. I know of no specific circumstances in which any negative consequences have been given. Some countries estimate that they will need no morphine and other medicines for the following year. I know of no circumstances where there's been any sanctions. I don't know if sanctions are the most appropriate thing to do in that circumstance, but certainly the global regulator can do more to support countries which are not doing anything to support the needs of their people.
Thank you.
I can see no more hands up, so I'll say thank you very much for listening to me, and I'll pass it back to Tim.